Our last speaker for the session and topic is lap repair of incarcerated hernias safe? Ahmad Elnahas, University of Toronto.
I'd like to thank SAGES for the opportunity to present our research today. I have no disclosures. Laparoscopic repair of abdominal wall hernias has actually been very well supported in the literature, especially in the elective setting. However, there is a lack of literature when it comes to the safety and feasibility of laparoscopic repair for acutely incarcerated abdominal hernias. So our study objective was to compare the 30-day complication, reoperation, and mortality rates between laparoscopic and open repairs of incarcerated abdominal hernias. Our complications were further characterized as either serious or infectious. We performed a retrospective cohort analysis using data from the National Surgery Quality Improvement Program registry, which is a very large national surgical database capturing 30-day outcomes in participating sites around North America. Our study population included cases where ICD-9 codes described abdominal wall hernias, either ventral or inguinal, where there was evidence of obstruction but without gangrene. We excluded all cases with documented bowel resection in order to improve the comparison between the two groups. Our table here describes the relevant patient characteristics between the two groups. The total number of patients in the laparoscopic group was 2,688, and total number in the open group was 15,562. There were several statistically significant differences between the two groups, especially with respect to preoperative comorbidities and operative characteristics, which we expected given the high likelihood that operative approach was dependent on patient factors. Of note here, laparoscopic surgery was more likely in patients who were obese, as well as patients who presented with ventral hernias. However, open surgery was more likely in those patients who presented with recurrent hernias and who had some sort of evidence of sepsis prior to their operation. The first table on this slide summarizes the outcomes in the two groups. And what we found was that complications, reoperations, and mortality was less overall in the laparoscopic group. However, given the obvious issue of confounding and selection bias in this situation, we performed a multivariable logistic regression analysis in order to adjust for confounding. But we still found that laparoscopic surgery was associated with significantly less infectious and serious complications. However, there was no significant difference with respect to reoperation or mortality. There's limitations to consider in this study given the retrospective analysis, and that is the issue of confounding. We did try to address that by including all of the clinically relevant confounding variables into our regression. However, given some of the limitations in our database, there was potentially unmeasured confounders. For example, there was no details with respect to certain operative characteristics such as the size of the defect or the type of mesh used. There was no measure of surgeon experience with respect to laparoscopic surgery, which could also potentially limit the generalizability of our results. So in summary, patients with laparoscopic repairs had significantly lower early morbidity compared to open procedures. And although the percentages were lower in the laparoscopic group, there was no significant difference in the reoperation or mortality rates. Our conclusion was that laparoscopic surgery appeared to be safe in the management of select incarcerated abdominal hernias. Thank you for your time.
Ahmad, one of the criticisms in NSQIP is you only get 30-day follow-up. Do you think if you followed any longer, your data would change or not?
I think that's a good question. This study was specifically addressing early morbidity, and I would assume that most of the complications from surgery would usually be around 30 days after the operation. However, you're absolutely right. It won't allow us to capture things like recurrence, which could definitely be well after 30 days.
Any other questions from the audience?
I wish to know whether it was a retrospective study. So whether you took into account that how many of these surgeries were attempted laparoscopically and then converted to open? Or was there any bias in the fact that only the easier surgeries which were successfully completed laparoscopically were taken into account to have a impact on the overall results?
That's a very good question. Unfortunately, the NSQIP database does not provide a variable for conversions. We did select our groups based on CPT code, so this is the principal and final code which was documented for that case. So the assumption is that if a case was coded as a laparoscopic case, it was completed laparoscopically.
Would you try all comers if you were, after doing your research, you yourself, how are you, what's going to be the determining factor with you?
Yeah, one of the things I didn't put up on the slide was some of the predictors for adverse events from our regression. So those really consisted of comorbidities and recurrent hernias. So those are some of the issues that I would think about before deciding whether or not to perform the procedure laparoscopically.
That's the question I was going to ask.
Yeah.
You've reviewed the data.
Yeah.
Can you talk about where, from that data and your comfort level and applying it to your practice, where would you use laparoscopic surgery for an emergency case? Where would you not use it?
Yeah, so I'd probably use it in a healthy individual who was just presenting with early obstruction, no evidence of any sepsis syndrome, no ominous signs on their CAT scan. Those are the cases I would probably pick for laparoscopic management.
And there were no inguinals in here, or do you know? There were.
We included inguinal hernias, correct.
There were inguinals
Yep.
in here. Any other questions? Thank you.
Thank you very much.